Alright, moving on. So why pigment gallstones are common in Asians? It's a good question. Uh, it could be because of the endemic, uh, nature of these gallstones presenting in Asians. Could also be because of different diseases that we have here that are prevalent, such as malaria or dengue, that results in breakdown of RBCs and stuff. So hence these pigment stones become more prevalent in certain areas as compared to Western population as well. But it's not uncanny to see cholesterol stones here as well. I would say, if anything, they're as common as pigment gallstones. These statistics might change over time, and I think right now what current guidelines state are basically mixed type of gallstones are the most common. But according to our source, Bailey and Love, we have to go accordingly because that's eventually what shows up in your exams as well. So it's better to stick to those statistics. All right, going back to the slides. All right, these were pigment stones. Okay. Next, we have these chocolate-colored stones. Can you take a guess what kind of stones are these? Their color resemble between those that have cholesterol stones और दूसरे pigment stones, right? इन दोनों के दरमियान का color है. So hence, these are known as mixed type gallstones. Mixed gallstones. ठीक है. Next, we have a diagram that's laying out these different steps of gallstones formation. In the top right left corner, we have the causes of gallstones. So too much absorption of water from the bile that is occurring can also lead to a increase in formation of gallstones. Secondly, too much absorption of bile acids from the bile. Third, too much cholesterol present inside the bile. Or fourth, inflammation of the epithelium inside the gallbladder. These are all factors or causes that can start the formation of gallstones. And next, we'll look in detail as to how these factors further roll the process ahead of gallstone formations. And on the right side of the diagram, after the gallbladder and gallstones, we have the CBD outlined through which the arrows are pointing down towards the pancreas and the pancreatic duct, which finally open into the papilla of Vater, right? This is where the normal flow channel of bile usually leaves the gallbladder, comes down the CBD, enters into the pancreas via the pancreatic ducts, and drains into the second part of the duodenum through the papilla of Vater. All right. Now, to further, look into the formation of gallstones, it starts with supersaturation of the bile, right? And there are different factors that lead to supersaturation of the bile, in which we have age, then there's the sex, the male, female, genetics, obesity, and the diet of the person involved. Further on, we look at the impaired gallbladder function. Impaired gallbladder function can constitute of three things: either impaired emptying of the gallbladder, impaired absorption of the gallbladder, and impaired excretion as well. Excretion of the bile salts to further enhance the effects of the bile. And then lower down we have the cholesterol nucleating factors, such as the mucus glycoprotein and infection that can also lead to gallstone formations. Lastly, we are looking at the absorption via the enterohepatic circulation of bile acids. So, your normal transit time about, if that is disrupted in any way, that can also lead to gallstone formations, along with if a patient has undergone ileal resection. He's not going to have as much of absorption of the bile acids through the enterohepatic circulation as well. That's also going to disrupt the normal flow and hence lead to formation of gallstones. All right. Gallstones can be of incidental finding. What does it mean? Incidental finding basically means a patient presented to you with, say, abdominal pain or say appendicitis or some other complaint, and you got a routine ultrasound done just to find out क्या दर्द हो रहा है किधर हो रहा है पेट में और उस पे जो है we find that basically the patient also has gallstones in the gallbladder. So that is known as basically incidental finding. ना उसको कोई symptoms थे और ना ही कोई presentation थी, signs ना symptoms कुछ भी नहीं, and on ultrasound हमें पता चला कि gallstones है, hence they'll be known as an incidental finding. दूसरी presentation जो हो सकती है, that could be an asymptomatic patient. Again, a patient who just presented to you with, say, some other XYZ complaint, and we find out that he's asymptomatic but has gallstones due to one or two signs, basically. Obstruction could be gallbladder colic. An obstruction is of gallbladder colic, which is a typical form of presentation of with gallstones, in which the patient is constantly complaining of pain in the right upper quadrant or right hypochondrium. And the pain is usually aggravated when after meals. When he consumes food is when the pain is aggravated. Relieved on rest, or basically just when he's not eating anything or lying down. But that's the typical gallbladder colic when the pain arises in the right hypochondria. And it's typical because usually most of the gallstones that do tend to progress further, they tend to obstruct the neck of the gallbladder and hence cause sort of an obstruction. And along with that, you get the gallbladder colicky pain that comes and goes, and it's sort of colicky in nature. Next, we could have an inflammation, which is also known as cholecystitis, and usually seen on ultrasound, in which they will note down that he has gallstones, but he also has inflammation of the gallbladder wall, or along with the gallbladder wall thickening, uske saath saath jo hai, uske around edema ho chuka hoga. Fluid will be around the gallbladder as well, which will all state that there's some sort of inflammation, and hence a diagnosis of cholecystitis can be made with or without stones being present. Now, stone might have passed through after causing cholecystitis, but the gallbladder wall thickening or inflammation states that, and then the diagnosis of cholecystitis. Jaundice भी हो सकता है, bile duct obstruction अगर होगी उसके साथ, you can also present with jaundice. Acute abdomen जो है will present with cholecystitis or perforation if it's an ongoing obstruction along with a super added inflammation. So eventually, क्या होगा? Perforation. When it perforates, it will create a picture of acute abdomen. The pain generalized all across abdomen, rigidity, guarding, and vitally जो है, it will all state towards an acute abdomen sort of picture. और उसके साथ साथ जो है, जब ये आपका perforate हुआ, by leak हुआ, it can also irritate the pancreas. Hence, it can also cause pancreatitis. Peritonitis, वही perforation of gallbladder, peritonitis हो गया, acute abdomen goes hand in hand. Intestinal obstruction can be caused as well. How? Either through a cholecystoduodenal. Cholecystoduodenal, meaning chole gallbladder, cysto the gallbladder cyst, मतलब कि gallbladder की जो cavity है, with the duodenum. Either a stone can eventually erode through the wall of the gallbladder and enter into the duodenum and cause an intestinal obstruction. Where will it cause an obstruction? In the terminal ileum, the most narrowest point of the small intestine. Yeah, choledocoduodenal. Choledocoduodenal means the gallbladder, the CBD, basically the ducts of the gallstone, right? Gallbladder. So it could be the CBD or the common lymphatic ducts, through which the stone could either erode through the walls and enter again into the duodenum, or it could also go into the transverse colon, because these are two parts of the intestine that are most closest to the either gallbladder, cholecysto, choledocoduodenal, or the CBDs. But over here, since we've highlighted only duodenal, we'll only discuss those. So it could either erode through the walls of the either gallbladder or the CBD, enter into the duodenum, and then obstruct the terminal ileum. So hence causing intestinal obstruction as well. Lastly, we have malignancy, which is gallbladder cancer. That can also the two presentations of gallstones as well. These are all variations of presentations that can occur with gallstones, and the patients can when patients present to us. Okay, now the nature of pain. What will be the nature of the pain? All right, now we're going to look at it in a little bit of detail. The nature or the character of the pain is going to be aching, burning, stabbing, constricting, throbbing, distending, or as we discussed, the colicky type, which is more and more common. Progression of the pain is, did it change or alter, is what you're going to ask the patient, right? Over time, has it increased? Has it decreased? Has it spread? What happened to the pain? How's the intensity of the pain? Uh, what else could you ask? The end of the pain, right? Describe how the pain ended. Was the end spontaneous or brought about by some action by the patient or doctor? Now, what does that mean? Was the end spontaneous or brought about by some action by the patient or doctor? We're going to actually discuss this, so we'll come to that. But I want you to remember that point. Was the pain brought by some action by patient or doctor? If you can think of it, there's a specific sign that we can elicit on examination that will determine. It's not. It just helps us guide us better in towards diagnosing cholelithiasis or gallstones. Now, duration. Record the duration of the pain. How long has it been going on for? Relieving and exacerbating factors. Take it. That's what we slightly went over before. Relieving factors like when the patient is just resting, lying down, could be one of the relieving factors. Taking maybe proton pump inhibitors or certain medications for pain, that could be relieving factors. Exacerbating factors for gallstones specifically, most commonly, what we see in OPD are patients presenting or basically when we eat some meal, uske baad hi jo hai, we feel an increase in pain. Next, we have the radiation, right? So you got to record the time and direction of any radiation of the pain. Remember to ask if the nature of the pain changed at the time it moved. Change at the time it moved. Referral, was the pain experienced anywhere else? And cause, why referral? Like, because everywhere in the gut, around the gut, in and around the gut, when you have a pain of some sort, it usually has referral pain as well. Such as basically for, in this case, gallstones. Let's talk about gallstones. And gallstones referral pain can be to the right tip of the shoulder. That's usually where they can also feel the referred pain. Actual pain is in the right hypochondrium, but referred pain will be in the right shoulder, on the right tip of the shoulder. Cause. Note the patient's opinion of the cause of the pain. That's also important. All right, over here now we have the general layout of the abdomen. Um, the usual distribution of the abdomen, how we divided it up into 9 segments. For it's beneficial for us doctors to come to a conclusion or diagnosis of what might be the root cause behind the pain originating in any of these quadrants. I'm not sure in second year if you guys have already gone over this, but it's better to know all the 9 quadrants, and it's also, I think, highlighted in the books as well. So over the top, if you're starting from the top right corner, we'll obviously have the, looking at from here in the top right corner, but the patient's from the patient side, it will be left hypochondrium, the LHC. In the center, we have, now we're moving towards the left. So start from the top right, moving to the top left corner. So we have the LHC, left hypochondrium. In the middle, we have the epigastrium, and then the right hypochondrium. Right hypochondrium is the area that we're focusing on. If you're looking at it from our view, it's the top left corner. This is where the liver, the gallbladder is. And the pain is usually in this area. Right below the right subcostal margin, we have the usual pain. And Obviously, referred pain could be on the right tip of the right shoulder. As we move down from the right hypochondrium, move one down. This is the left lumbar. ठीक है, उसके नीचे जो है नहीं सॉरी राइट लंबार, उसके नीचे राइट इंग्वाइनल या राइट इलियक फॉसा हो जाएगा, जिसमें अपेंडिक्स वगैरह भी ओरिजिनेट होती है. The centermost area where there's the umbilicus is the umbilical region. If we move to the right of the umbilical is the left lumbar region. Move down from the left lumbar, we have the left iliac fossa. And in the middle, in the lower middle, we have the suprapubic. But we need only concern with the right hypochondrium. Looking at it from our perspective, it's the top left corner of the abdomen. All right, moving on. Complications of gallstones. Right. What could happen? We slightly went over it in the talking about the nature or the way the patients can present. We have basically the stone that could slide out of the gallbladder and then slide further down the cystic duct, come all the way down to the pancreas, and then either obstruct it there inside the pancreas, inside the pancreatic duct, causing pancreatitis, or go on further down into the ample of water, obstructed there. But if you're moving back, obstruction could be anywhere from the cystic duct all the way down to the pancreatic duct if the stone is too big and it cannot pass through that easily. Gallbladder के अंदर जो है inflammation हो सकती है because of the gallstones, like we discussed, cholecystitis, can also be one of the complications, and it could become aggravated and cause mucoceles, which are mucus retention cysts inside the gallbladder wall, and also empyema could become infected, and empyema means pus basically inside the gallbladder wall. Okay, here, all right, nice. We've got a whole list here. The biliary colic, the pain, and then sort acute cholecystitis. ठीक है, वो हम डिस्कस कर लिए. Mucocele हो गया, empyema हो गया, gangrene obviously obstruct करता रहेगा, तो eventually अगर जो वो empyema or mucocele है, and if it aggravates, it could eventually lead to gangrene of the gallbladder. And before it gangrenes, it could also perforate, hence leakage of the bile throughout the abdomen, causing an acute abdomen or peritonitis, biliary peritonitis. Then we have chronic cholecystitis, like we said, acute cholecystitis. Gallbladder cancer can also occur. It's a long-term complication of gallstone. Then we have, what does it say here? Sorry, my bad. Chat's getting in the way. Obstructive jaundice, as we discussed, if the stone obstructs anywhere between the cystic duct all the way down to the pancreatic duct, what will it do? It will eventually lead to blockage of bile flow all the way up to the liver, and then hence cause jaundice. Cholingitis is also an inflammation and infection that originates in and around the gallbladder, and it can ascend up into the liver as well, hence known as ascending cholangitis. Acute pancreatitis, like we discussed as well, can occur. And last but not least, small bowel obstruction as well. If the gallstone erodes through the wall of the gallbladder or the biliary tree, entering the duodenum, and enable to pass through the into the cecum and pass down the pathway, can obstruct the small bowel as well. So over here we have a picture of, I don't know if you guys can guess what this is, but this is in the centermost, slightly towards the top is a gallbladder. And if you can note, there's increased amount of distension in the gallbladder. There's also erythema, inflammation surrounding gallbladder wall, suggestive of chronic features of gallbladder. Distension also states chronicity of this gallbladder. From this picture, from this point of view, you can also see a laparoscopic port being entered on the far right of the picture. So this is most likely the patient is undergoing a laparoscopic cholecystectomy for this distended gallbladder, and most likely because of gallstones. It says acute cholecystitis. All the features described suggestive of cholecystitis. Again, over here, there's another view of a laparoscopy cholecystectomy, most likely, and it's showing a mucocele of a gallbladder. It's not so clear, but you can see a slightly demarcated region on the gallbladder wall. All right, let's see what you can, if you can take a guess at this. What is this? It's definitely a gallbladder which has been laid open. Inside you can see wet stones. They're black in color, so hence pigment stones. But along with that, you see pus as well. So it's most likely suggestive of empyema or gallbladder. Okay, this is exactly what it looks like. A frank amount of pus is present. Gallstones are there as well. So it's secondary to gallstones, and gallbladder wall is thickened. You can see its edges. It's thickened and it's inflamed. So you get erythema be around the outer wall of the gallbladder. All right, moving on. What is this? Can you take a guess? The color of the gallbladder is green. Again, there's coarse amount of inflammation. It's a gangrene. The color states its diagnosis basically is greenish and suggestive of gangrene of the gallbladder. Again, the patient's undergoing a laparoscopic procedure, most likely laparoscopic cholecystectomy as treatment for this. All right, signs. Which signs? What are some of the signs that you can see in a patient presenting with gallstones? There are various signs, obviously, that a patient could present with. A few are listed in this picture right here. We could have fever, chills, ठीक है. उसके साथ itching भी हो सकती है. This is sort of vague, but most likely if the patient is undergoing or under like patients presenting with jaundice, उसमें usually the bile, when there's increased total bilirubin, it leads to itching as well. The other sign that is highlighted, which is more significant for us, is the pain in the right upper quadrant. Right upper quadrant, right hypochondrium, जो भी कह लो, abdominal pain in that region. जिस जगह उसने हाथ रखा हुआ है, it's right below the right subcostal margin as well. ठीक है, उसके साथ साथ क्या है important चीज़ जो है Charcot's triad है, ठीक है, ascending cholangitis का. उसमें क्या होता है Charcot's triad में ये हमने highlight कर दिया. फीवर होगा, बुखार होगा, जॉन्डिस होगा और उसके साथ साथ राइट अपर क्वाड्रेंट पेन है. All right, let's see if you can brainstorm as to what is being shown in these four pictures here. I'll give you a few seconds here to see if you can figure out what these pictures are depicting. It's in a stepwise order. It starts on the top left, goes to the top right, comes down to the bottom left, and then finally you have that thing in the bowl on the top bottom right. Top left, what do we see? We see small bowel, along with its omentum that's attached to it, but the tube that is the small bowel. Inside the small bowel, you can slightly make out उसके नीचे वाले margins पे there's a slightly blackish tinge. That most likely, if you were to feel it, palpate it during surgery, it would feel as a hard or hardened material inside it. Not necessarily adhered to that specific part of the bowel, but if you were to milk it, it wouldn't go that far because looking at the size of that object, it wouldn't pass through the ileocecal valve. Anyways, moving on to the top right side of the picture, you see they've made a small incision with a cautery lead on the small bowels, and then it seemed to be milking that object out. Bottom left picture, you see that object has been completely retrieved from inside the bowel and emptied out onto the abdominal sponge. Finally, has been put into the bowl on the bottom right corner, and most likely what this object is a stone. ठीक है? Known as, this presentation is usually known as ileal stone, right? Causing small bowel obstruction. As you can see on the top left, there's not a remarkable but a slight distension in the bowels as well. The proximal segment specifically, and the distal is it's normal. Proximal is distended. See, this is ileal obstruction due to gallstone. Now, this gallstone, how did it get here? It could be one of the either two ways. Either it rode it through the gallbladder wall and emptied into the gallbladder, or through one of the biliary tree or tracts and into the duodenum. Gallstone ileus. Mechanism of fistula and gallstone ileus. This is a nice diagram. This is showing you exactly what we've been discussing before as well. And there's a diseased gallbladder in green. उसके अंदर जो एक white से जो structure पड़ा हुआ है, that is the gallstone. And obviously when there's a diseased gallbladder that has undergone, cholecystitis or even a long-standing gallstone over some time, can lead to adhesions that are shown on the left to the lateral abdominal wall, or can lead to adhesions to the transverse colon, which is the large bowel. Now, it is through these adhesions, most likely, that the gallbladder will further erode and the gallstone can pass through. इसमें जो है दोनों through the cholecysto-enteric fistula. Enteric मतलब कि gut में आ रहा है, superior part of duodenum, उसमें सीधा आ गया, या फिर transverse colon में भी जा सकता है. Again, we have another picture showing gallstone ileus. There's the site of impacted stone inside the small bowel. You can see it is a small bowel because it doesn't have the ulcerations nor the tinea coli attached to the sides of the bowel. That's in the top picture. That is before it opened, and on the bottom right, this is after it has been laid open, and that is the gallstone inside. Alright, which investigation are you going to do? Or is this, specifically this image, what investigation is this? Can you take a guess? Is it an X-ray, MRI, CT? What is it? And of what specific area is it of? What do you see inside? Can you guys just jog your memories a little bit? Jog your brains. Try to think. Okay. This is basically an X-ray, alright? X-ray of an abdomen. And the arrow pointing to a structure in the bottom, if you'll see the white arrow, is the gallstone ileus. Yeah. What investigation is this, and what do you see, basically? This is a ultrasound, all right? An ultrasound, the whole black structure on the top of the picture that looks like a bean shape is the gallbladder. And inside it, what you see is some whitish structure. That is the gallstone. And it's a stone because in ultrasound, what do we see? We see echoic shadows. अब उस gallstone से अगर आप नीचे follow करो, what you see is a black shadow or a line going longitudinally from that white structure all the way down. That is the hypoechoic shadow because of the gallstone inside the gallbladder. Here we have another investigation. ठीक है इसमें भी जो है this is CT scan and what we see is basically gallbladder on the top left. ठीक है and the structure that is white and being highlighted in the middle of the image that seems to be within the bowels is the gallstone. Gallstone, specifically gallstone ileus, most likely in the small bowel. All right. Now, to run the diagnosis, before we run the diagnosis, what are the key components of it? We have history, we have examination, and then we have imagings as well. So, we have ultrasound, we have CT, we have blood tests, CBC, LFT. Why are they all important? Because they will guide us in caring better for the patient. Initially, history and examination along with imaging helps us confirm our diagnosis, most likely that we could have concluded towards or from examination. And then we run the blood tests. Why? Because we got to operate, right? When we come to the diagnosis of gallstones, the ultimate treatment for gallstones is always surgery. So we need to run diagnostic tests. Not diagnostic, my bad. We need to run blood tests in order to see if the patient is going to be able to withstand the surgery or not. So CBC, LFTs, along with other baseline investigations is also necessary, such as RFTs, LFTs can liver function tests. ठीक है ना CBC से हमें complete blood profile picture पता चल जाएगी. उसका hemoglobin कैसा है, TLC count raised है कि नहीं है, platelets कैसी हैं and everything else. LFT से liver function test पता चल जाएगा. Whether or not just a patient jaundice है कि नहीं है, that can show up in LFTs along with the liver parenchyma के बारे में भी थोड़ा बहुत. इसके अलावा baseline investigations में what we routinely do are renal function tests as well, because the patient has to undergo general anesthesia for continuing with the procedure or surgery. So we need to be able to see whether or not he or she will be able to withstand the general anesthetic drugs, such as isopropofol and everything. कि renal clearance वगैरह जो है सही तरह हो सकेगी नहीं. तो RFTs भी baseline में होने चाहिए along with Hep B and Hep C screening. और क्या chest X-ray along with ECG and also clotting profile. PT, APTT, and INR should also be done of the patient. Now, this is the sign that we can elicit of the patient on examination that we discussed earlier that I said that we'll come back to. It is known as a Murphy's sign. I don't know if any of you have read it or heard of it. And this is usually a typical or classical sign that can be elicited on a patient with acute cholecystitis. ठीक है, इसके 3 steps and 3 से 4 steps. पहला step वही है कि ask the patient to exhale. ठीक है. Once the patient has exhaled, the examiner or you place the hand below the right costal margin. ठीक है, in the mid-clavicular line. ठीक है. Now the patient is instructed to inspire. जब आपने हाथ रख दिया, exhale पहले exhale कर लिया patient ने, you place your hand below the right subcostal in the mid-clavicular line, then you ask the patient to inspire. Now, the patient, while inspiring, will stop breathing and winces with a catch in breath. Winces meaning you make a like usko pain hoga, so he's gonna wince. Matlab he feels pain, so he's gonna show that kind of pain on his face. So he's gonna react to it, hence is known as winces, and will catch his breath. He will stop breathing because of the pain that you've elicited. And the pain was elicited why? Because of the acute cholecystitis. The inflamed jagah hai. So once you did that maneuver, what happened was you irritated that area, and it caused because of the irritation, the patient has stopped breathing catched his breath and winced, मतलब expressed pain in that region specifically. ठीक है ना? Now, moving on. Sign of pancreatic cancer. That is Courvoisier sign. ठीक है, इसमें क्या होगा? There's a palpable and large gallbladder with jaundice. ठीक है ना? And cause is unlikely to be gallstones. ठीक है ना? And this sign implicates possibility of malignancy of the pancreas. ठीक है, why can it be confused with gallstones as well or an obstructive picture? Because it causes an obstructive jaundice. And as you saw earlier, the bile that is being drained from the gallbladder passes through the pancreas as well via the pancreatic duct before it empties into the second part of the duodenum. So if there's a pancreatic cancer, most likely when it causes obstructive jaundice in the head of the pancreas, it causes an obstructive jaundice, right? So along with that, if you have a palpable and large gallbladder with jaundice, is unlikely to be gallstones, and this sign implicates that there's a possible malignancy of the pancreas involved in this. No, management. Tika, these are the findings of the gallstones that we can overcome. The list stated basically the incidental finding patients, the completely asymptomatic ones, the obstructed ones, which can present with the biliary colic nature of a pain. Then there's the inflammation, cholecystitis, acute or chronic, jaundice, bile duct obstruction, acute abdomen, just make cholecystitis, perforation, or pancreatitis, peritonitis as a result of the perforation of gallbladder, intestinal obstruction, cholecystoduodenal or colicoduodenal fistulas, or even malignancy, gallbladder cancer. Now we're going to look at the management for each one. Say if you have the incidental or the asymptomatic gallstones, what do? Simple thing is just leave it alone. You not do anything whatsoever. Instead, you can tell the patient if ever you have symptoms such as the pain in that area, then only then proceed to see your surgeon. Otherwise, don't need to do anything. Don't need to advise any sort of medication. No PPIs, no pain analgesics, no pain meds, nothing. It was just an incidental finding and is not causing any pain. It's best to leave it alone. Next is the biliary colic, the symptomatic patients, basically. What do? We start right away with the conservative management, which requires what? Analgesics to relieve the pain of the patient. You can give him PPIs because acidity can occur as well and helps with gastric emptying and everything. So PPIs, antibiotic if it's needed. Usually pre-op, so pre-op antibiotics could be given as well. Or if it's in a state of acute cholecystitis or in a cholingitis, then we'll have to give him a treatment of antibiotics along with pain and PPIs, and then plan for surgery in the coming months. Usually 6 weeks, I think. So this is known as the elective surgery. We'll plan for it and we'll proceed after we've gotten all the fitness, general anesthesia fitness ho jayegi, baseline investigation ho jayegi and everything. Then we plan to put him on the list. It's not an emergency. And we can follow through with it, not necessarily after a certain period, but in the following few days after all these investigations have been done. That was for the symptomatic patients. Then we come down to, this is the delayed surgery one. The acute chole ones. We do not operate them right away because we're going to ensure that the cholecystitis or the inflammation of the gallbladder has calmed down, has been completely treated first, and then plan for surgery at a later date. So this is known as the delayed surgery or interval cholecystectomy. After a certain interval has passed in which you ensure that the inflammation of the gallbladder has calmed down, we then proceed with the surgery, whether it's open cholecystectomy or laparoscopic cholecystectomy. See, next we have the obstructive jaundice. ठीक है. Obstructive jaundice, first thing what we need to do, we're not talking about surgery right away. Because for an obstructive jaundice, we need to figure out where the obstruction is, right? Is it intrahepatic, posthepatic, prehepatic, where? Which can constitute a lot of places where these obstruction can happen. So first thing we got to do is obviously investigate the cause. How do we investigate causes? There are multiple ways to investigate. We could run routine blood investigations along with radiological investigations as well. So starting with investigated causes, जो है उसमें we could do LFTs, we can do ultrasound. ठीक है, ultrasound से हमें further guidance मिल जाएगी कि gallstones है तो किधर है gallbladder में, or they obstructing the neck of the gallbladder, or is less likely you'll see an ultrasound report stating the possibility. There's possibility you could see a stone in the CBD, common bile duct, that could be obstructing, that could be causing obstructive jaundice as well. However, in LFTs, we can also find out whether or not it's pre or post hepatic or intrahepatic based on the total bilirubin में indirect or direct bilirubin कितना raised है, whether or not conjugated or unconjugated. Radiologically जो है, we can also investigate it via MRCP या ERCP, but ERCP will be better in that case that we can, once we figure it out it's an obstructive jaundice of the bile ducts, then it's better to proceed with ERCP. What does ERCP stand for? Endoscopic retrograde cholangiopancreatography. Okay. We go in with the scope or a camera through the esophagus. We go down up to the second part of the duodenum where the opening of the ampulla of water or the pancreatic duct is, along with the so we go through that and we go retrograde. We're going up now. From the bottom, we're going up in towards the pancreas. Take a look at the pancreas, whether or not there's a gallstone, maybe inside the pancreatic duct. If there is, then you just remove it. So this is the beneficial factor of ERCP over MRCP, which is MRCP. What is MRCP? Which is MRI basically. It stands everything same way as ERCP, but it's just an MRI inside of the whole cholangiopancreatography of the biliary tree and everything. So it's beneficial from MRCP in the sense that it is both diagnostic and therapeutic as well. So once we've gone in from the second part of the duodenum up and now moving up towards the biliary tree, we can see where the obstruction is, and after we've identified the obstruction, we can also relieve the obstruction. ठीक है, या फिर surgery. इसके लिए वही है कि आप surgically भी इसको remove कर सकते हैं जाकर. Now, what is conservative treatment? What is resuscitation? What will be definite treatment? And so treating, what is treating a patient? Treating a patient without any intervention or surgery, taking a process of correcting physiological disorders in an acutely unwell patient. That is by definition what this means basically. Conservative management. What is the conservative way? हो गया हमने इसको NPF भी करके patient को catheterize कर दिया for intake and output monitoring. How do we catheterize? मतलब कि passing the Foley's catheter. Intravenous fluid हम खुद डालना शुरू कर देंगे, so we'll have a better monitoring of intakes. Parenteral analgesia, IV parenteral, so you can analgesia दे देंगे. Intravenous antibiotics. Parenteral anti-ulcer drugs भी दे सकते हैं. Antiemetics and strict monitoring. ठीक है. कुछ patients में अगर आपके पास obstruction वाली picture है तो we can also pass an NG tube. ठीक है. Decompress the bowels before proceeding. It will be part of the conservative management. Now, can you take a guess at what kind of procedures we're doing? Obviously, on the left, we're doing the laparoscopic. We have the ports. And on the right, we have the open. अब इसमें काफ़ी beneficial होती हैं laparoscopic over open. Obviously, जो ऐसी picture में वैसी नज़र आ रहा है आपको. वो है कि open में जो है we've given a long incision in the right hypochondrium, right below the subcostal margin, whereas on the left side, in the laparoscopic side, you see there's only minimal 5 mm to 10 mm incisions in which through we've passed the ports as well. So they're both forms of cholecystectomy, either laparoscopic or in open. Which one would you prefer? Let's see. What do you think is beneficial? Just looking at it, from this picture stating and the basic information that you do know about each of these procedures, which one would you prefer doing, a laparoscopic or an open, and why? All right, hold on to your answers until later, after we're going over the benefits of laparoscopic procedure first. What do we have as benefits? There's reduced wound access trauma. Like I said, a 5 mm to a 10 mm incision, which is very minute for any procedure or surgery, in which we can easily pass the ports and then proceed with our procedure. Okay. There's a less post-operative pain. Obviously, smaller the incision, less the pain. Pain due to obviously removal of the gallbladder from the liver. That's different, but talking about pain of the surgical site is much less compared to an open cholecystectomy. Less disfiguring than conventional techniques. This disfiguring of what? Basically the abdomen, the skin, the overlying skin. So it's more pleasant for the patients to look at. ठीक है ना? They feel more comfortable undergoing laparoscopic because of that. Basically, cosmetic reasons की वजह से, then this is more beneficial to them, especially if the patient is middle-aged female. Uh, for them, it's more of their concern. It should be cosmetically pleasant as well. Cost effectiveness, both to patient and the health services. In what sense? Cost effectiveness to both patient and health services, in the sense that there is a less hospital stay. So there's fewer hospital fees in the sense that there will be less money being spent on, say, dressings, daily dressing change, along with the hospital charges for the bed, along with the antibiotics that will be needed every day. So it's cost effective for the patient and for the health service as well, because the shorter the stay of the patient, the less that you got to look after, and the more cycle of the patient, more other patients can come in as well. So less bed occupancy in the end. Shortened operating times. Obviously, laparoscopic requires shortened operating times than open. Shortened hospital stays. वही वाली बात आ गई. Early recovery has been less. The size of the incision is small as well. So there's basically early recovery in this case as well compared to open, and allows faster mental and physical recovery as well. Now, small wound size for access. Wound pain is reduced. The benefits, we're looking at the benefits of the small wound size. Wound pain is reduced. Infection, उसके chances reduce. Bleeding automatically reduce. Dehiscence, इसमें dehiscence meaning कि जो wound बंद हो जाना और फिर दोबारा नहीं खुलना, dehiscence इसमें दोबारा फिर खुल जाना, इसमें nil है. Hypothermia, because there's minimal access, so there's minimal heat escape. Hypothermia के chances कम है. Heat जो है इतनी escape नहीं होती, nil. Fluid loss, nil. Adhesions, minimal. There's small incisions, right? Small incisions mean that they're recovering quicker without need for more fibroblasts, and adhesions chances are also automatically decreased. Herniation chances, they're also minimal because the port sizes are so small. But however, there are chances of herniations, and in laparoscopic, the most common site for herniations will be through the umbilical port. As this is the port which is in which the incision is the biggest out of all the other ports, and the reason for that is because it is through this port that we take out the gallbladder. Nerve entrapment is also minimal. And surgeon vision is automatically improved because it's laparoscopic. So once you introduce the camera inside, you get to see pretty much the whole abdomen, if not the gallbladder, easily. And that is pretty much it. That's the end of the lecture. If you guys have any questions, feel free to ask. Still have a few minutes left. Thank you, and have a nice day. Stay home, stay safe. Assalamu alaikum. If you guys still have a question, you can still ask me. I'm still here. Bye, Basam. Yeah. ये दोनों तुम सुन
सर हो गया लेक्चर खत्म